Hello and welcome to another in the series of You Ask, We Answer, where we're answering some common clinical questions that have come through to us here at Oscar. So I'm Anita Morton, I am the clinical support nurse at Oscar.
And I'm Valerie Daly, I'm an independent tissue viability nurse who works with Oscar.
So let's have a look at another of the questions that's come through to us. So the question was, how do you deal with category 4 ulcers on the heels?
It's a big question, isn't it, Anita? Okay,
Absolutely.
so if we look at, so we have here a nice category, probably 4 pressure ulcer on a heel. So I think that it is the key here before anything happens is that the patient has a really good holistic assessment and has really good risk assessment in place, and that's right from the moment of admission to that point of care, because what you want to try and do is predict that somebody is at risk of developing a heel pressure damage, because obviously we would prefer to get them and them not happening than to have to deal with how the consequences of and struggle to heal this, because they can be very difficult to heal, especially on elderly patients. So it's really important to look at the patient's condition and their physiological condition. And if you listened to our previous question around how pressure ulcers develop and the intrinsic and extrinsic factors, they are the real important things that we need to be able to look at. And it's especially important for patients who may have an issue with the blood supply to the foot. So people with peripheral arterial disease or diabetes would be immediately at risk of developing heel damage if they became immobile. And also patients who are maybe have reduced lower limb mobility, so maybe with a fracture, knee replacements, hip replacements, even patients whose limbs are contracted have a very high risk. So I think the first thing to say is that it's really important that we fully assess our patients to the highest quality and decide in advance if they are at a higher risk of developing pressure ulcers to the heels. And one of the things that we should be thinking about doing in that is about how we assess the blood supply to the foot. And it is with NICE guidelines, and the National Wound Care Strategy is around undertaking a vascular assessment on these patients. So we would look at maybe doing a Doppler ankle brachial pressure index to see what the blood flow is, or that we would be maybe listening to the sounds of the arteries in the feet to hear if they are sort of biphasic or triphasic, or we would be getting either a vascular referral or even referring to tissue viability to help us to come to that decision. That's obviously when they have developed a heel ulcer. So Anita, do you want to talk about how we might, heal an ulcer if we've been unfortunate enough to have a patient who has developed one?
Absolutely. So the key really is to offload the heel. We want to take the pressure away completely. So we may call it offloading. You may also hear it being called floating the heels. And we would do that then in conjunction with the most appropriate dressings and things that we would assess that wound as requiring. So there are lots of different products we can use out there to offload the heels. We can use specialised boots, and there are lots of different boots available on the market. There's wedges that you can apply onto the mattresses, put into beds. Some people are using pillows. They're not completely recommended, because ultimately with pillows they come in different kind of thicknesses, and they often compress quite quickly. So as soon as we popped it underneath the leg and the heel to float the heels, that the pillow often then depresses, and so the heels end up back on the mattress. If they are the only thing you have to hand, and you really do need to get those heels offloaded, then you can use them. But we would be cautious about using pillows, and just make sure that you lie the pillow lengthways, so that you've got 2 pillows, essentially 1 for each leg, so that we're also supporting the calf as well.
And try not to have those pillows with the plastic covers on them, because that increases that sweating and microclimate that we talked about.
Absolutely, yeah, no, good point, Valerie. Yes, yeah, please don't have any plastic covered pillows at all. There are other products out there. So we have our Series 2 mattress here at Oscar that has our heel offloader. So if we can just have a look. Our Series 2 mattress comes with 2 layers of foam, and the top layer of foam can be positioned, so rolled, so that we can then create an offloading effect. And if we were to zip that cover up again, you can see that the heel is now on offloaded completely, so I can get my hand there obviously between the mattress and the heel. And then what we've also got then is good support on the calf as well, and pressure redistributing support on the calf too. So this is a really handy feature of the Series 2. And also some of our other mattresses will come also with the heel offloader as well. A lot of our mattresses also have a heel slope to them, which doesn't completely offload, but it will certainly help to reduce the pressure under heels. And as and when you raise the knee break, that heel slope will help to take quite a bit of the pressure away. But if you are dealing with category 4 pressure ulcers, we really need to be thinking of floating, offloading those heels as much as possible.
And then just to sort of round this all up, when it comes to, and I know when people ask about healing, they often mean dressings and what do I need to do. I think that you definitely need to have the input of somebody who is very familiar with healing that type of wound, or look at getting a specialist in to help, because there are many things that you need to consider. So if it was necrotic, can I debride it or not debride it? Because that depends on whether the patient has diabetes or peripheral arterial disease, or whether they have the capacity to heal, whether they're end of life and healing's not not an outcome that you're looking for. And then if it is sloughy, then how do we move that on? And then if it is got high exudate, what products that we need to use? So it is really multi-layered. What I would say is to try and not let heels get soggy and wet. So certainly where I used to work, we stopped using foams on heels because they weren't soaking up enough of the exudate. They weren't managing that exudate very well. And obviously with foam, sometimes when you stand on them, if a patient was mobile, it squishes back out some of the exudate in there. So we would look at maybe using a super absorbent type dressing. And also be careful about sort of bandaging from toe to knee on patients with heels, because that just covers up all the other areas, doesn't it? Absolutely. So it means it reduces the nurses and the clinician's ability to keep an eye on other potentially high risk areas on the heels. So get advice, get somebody in who's dealt with that before, maybe a senior member of the team, or even if you're in a care home setting, put the feelers out to other care homes that you might have somebody who's more experienced who can help to advise. There's lots of stuff online that you can do around wound healing, or even the Oscar Academy has we have some information on wound healing. So we hope that's helped.
Yes, thank you ever so much for listening and watching, and we will see you again soon for some more You Ask, We Answer.